Most people think of the kidneys as a filtering system, and that description is accurate as far as it goes. Your kidneys do filter your blood, removing waste products and excess fluid and sending them out of the body through urine. But the filtering analogy misses something important about what kidneys actually do and why losing them, even partially, is one of the most consequential things that can happen to a human body over the age of 60. Your kidneys regulate blood pressure. They control the balance of electrolytes, sodium, potassium, phosphorus, that determine whether your heart beats rhythmically or irregularly. They produce a hormone called erythropoietin that signals your bone marrow to make red blood cells. They activate vitamin D, without which calcium cannot be absorbed into bone regardless of how much you consume. They manage fluid volume throughout the body in ways that affect the function of every organ system. When kidney function declines, whether through disease, damage, or the specific mechanism I'm going to describe today, none of that happens cleanly. Blood pressure becomes harder to control. Electrolyte balance becomes precarious. Anemia develops. Bones weaken. The cardiovascular system faces additional strain. The entire biological architecture of the body begins to shift in ways that accelerate illness and reduce the physical quality of the years ahead. Chronic kidney disease affects approximately 37 million adults in the United States. It is the 9th leading cause of death. And in adults over 60, the prevalence is significantly higher than in younger populations. Estimates suggest that somewhere between 30 and 40% of adults over 65 have some measurable reduction in kidney function, the majority of whom have never been told this because chronic kidney disease is largely without symptoms until it has progressed to an advanced stage. I am telling you this not to alarm you, but to give you the context that makes what I am about to describe genuinely urgent rather than merely interesting. Because there is a specific substance, one that most adults over 60 have in their medicine cabinet right now, one that is sold without a prescription, in every pharmacy and grocery store in this country, one that is recommended casually and taken routinely for everything from a sore back to a headache, to the inflammation of arthritis that has a documented, well-characterized dose-dependent toxic effect on kidney tissue. And the reason most people taking it regularly have no idea about this risk is that the damage accumulates silently. There are no symptoms in the early stages. The pain that the medication was taken to relieve is gone, so the body feels better, not worse. The kidneys are quietly sustaining damage that will only show up months or years later on a blood test, if anyone thinks to order one. The substance is non-steroidal anti-inflammatory drugs, NSAIDs, ibuprofen, naproxen, the medications you know by brand names that are household words throughout the Western world. Before I describe the mechanism, and the mechanism is important enough that I am going to spend real time on it, I need to say something clearly, because I do not want you to walk away from this conversation having misunderstood the message. I am not telling you that taking ibuprofen once for a headache is a medical emergency. I am not telling you that these medications have no legitimate uses. They do. They are effective anti-inflammatory and analgesic agents with genuine medical applications. And in the right context, taken at the right dose for the right duration under appropriate medical guidance, their benefit profile justifies their use. What I am telling you is that the way these medications are actually used by most adults over 60, regularly, often daily, sometimes for years, for chronic pain management, because they are available without a prescription, and because nobody explained the kidney risk, is a pattern that the nephrology literature has been raising serious concerns about for decades. And those concerns are not adequately communicated on the label, in the pharmacy, or in many clinical settings. This conversation is about closing that gap. Here is the mechanism, and I want you to understand it clearly, because this is the kind of knowledge that does not leave you once you have it. Your kidneys receive approximately 25% of your total cardiac output, meaning 1/4 of everything your heart pumps goes directly to your kidneys with every beat. The reason for this extraordinary blood supply is that the kidneys are continuously filtering, processing roughly 180 liters of blood plasma every 24 hours, from which they produce approximately 1 to 2 liters of urine. That filtration process requires both adequate blood volume and adequate blood pressure at the level of the filtering units, tiny structures called glomeruli, that do the actual work of separating waste from the substances the body wants to retain. Maintaining that pressure, in a system where blood pressure naturally fluctuates, throughout the day is the job of a set of chemical signals, including a group of signaling molecules called prostaglandins. Prostaglandins produced locally in the kidney. But the kidneys depend on prostaglandins not for inflammation, but for perfusion regulation. When NSAID use suppresses prostaglandin production in the kidney, the afferent arterioles lose the dilating signal that maintains filtration pressure during periods of hemodynamic stress. blood flow to the glomeruli decreases, and flow through the filtration units even when systemic blood pressure drops temporarily, as it does during physical activity, sleep, mild dehydration, or any hemodynamic stress. NSAIDs work by inhibiting the enzyme systems, specifically cyclooxygenase 1 and cyclooxygenase 2, known as COX-1 and COX-2, that produce prostaglandins throughout the body. This inhibition is what makes them effective anti-inflammatory agents. Prostaglandins are central mediators of the inflammatory process, and reducing prostaglandin production reduces inflammation and the pain associated with it. That is the therapeutic effect you feel. But the kidneys depend on prostaglandins not for inflammation, but for perfusion regulation. When NSAID suppresses prostaglandin production in the kidney, the afferent arterioles lose the dilating signal that maintains filtration pressure during periods of hemodynamic stress. Blood flow to the glomeruli decreases. Filtration rate falls. In a healthy young adult with normal blood volume and normal cardiovascular function, this effect is usually compensated for and does not cause lasting damage from occasional use. Filtration rate falls. In a healthy young adult with normal blood volume and normal cardiovascular function, this effect is usually compensated for and does not cause lasting damage from occasional use. In an adult over 60, the situation is fundamentally different in ways that make the risk substantially higher. First, kidney function naturally declines with age even in the complete absence of disease. The glomerular filtration rate, the standard measure of kidney function, decreases by approximately 1% per year after the age of 40. By 65, many individuals have lost 20 to 25% of their kidney function simply through normal aging, without any diagnosis of kidney disease. This means the starting point is already lower. The reserve capacity that buffers the effect of NSAID-induced reduction in renal perfusion is reduced before the first pill is taken. Second, older adults are significantly more likely to be taking other medications that affect kidney perfusion simultaneously. ACE inhibitors and angiotensin receptor blockers, among the most commonly prescribed medications for blood pressure and heart failure in this age group, block a separate component of the kidney's autoregulation system, the renin-angiotensin-aldosterone axis. Diuretics, another mainstay of cardiovascular management in older adults, reduce blood volume. The combination of an ACE inhibitor or ARB, a diuretic, and an NSAID, a combination so commonly encountered in nephrology practice that it has been given the informal name the triple whammy, creates a near-perfect storm of disrupted renal perfusion that can cause acute kidney injury even with short-term NSAID use at standard over-the-counter doses. A 2013 study published in the British Medical Journal found that the combination of an NSAID with an ACE inhibitor or ARB or with a diuretic doubled the risk of acute kidney injury. The combination of all three, the triple whammy, increased that risk dramatically further, with the greatest risk in the first 30 days of combined use, but with significant risk extending beyond that. Many people taking this combination do not know they are taking it because the NSAID was purchased over the counter without any medication reconciliation taking place. Third, older adults are more likely to be in states of mild chronic dehydration. The thirst mechanism becomes less sensitive with age. The physiological signal that triggers drinking in response to fluid deficit becomes blunted, meaning older adults frequently do not feel thirsty in proportion to their actual hydration need. Mild chronic dehydration reduces circulating blood volume, which places the kidneys in exactly the hemodynamically stressed state in which prostaglandin-mediated dilation is most critically needed, and in which NSAID suppression of that dilation has the most severe consequences for filtration. Fourth, the prevalence of other conditions that independently compromise kidney function, hypertension, diabetes, cardiovascular disease, atherosclerosis affecting the renal arteries, is substantially higher after 60. Each of these conditions reduces the functional reserve of the kidneys and narrows the margin of safety available when additional renal stressors like NSAIDs are introduced. The result of all of these compounding factors is that an older adult taking ibuprofen or naproxen regularly is doing so in a biological context where the kidneys are significantly more vulnerable to perfusion-related damage than they would have been 20 or 30 years earlier, and where the consequences of that damage compound with other conditions and medications in ways that can accelerate the trajectory towards serious, irreversible loss of kidney function. There are two distinct patterns of NSAID-related kidney damage that the nephrological literature describes, and both are relevant to this conversation. The first is acute kidney injury, a sudden, significant decline in kidney function that occurs in the setting of NSAID use, particularly in the context of volume depletion, hemodynamic stress, or concomitant use of other nephrotoxic agents. Acute kidney injury from NSAIDs can range from a mild, transient elevation in creatinine that resolves when the medication is stopped, to severe acute renal failure requiring dialysis. In many cases, particularly milder cases, there are no symptoms. The person feels no different than they did before, and the injury is detectable only through a blood test showing elevated creatinine or reduced eGFR. Without that test, it goes entirely undetected, and the kidney tissue that was damaged does not fully regenerate. Each episode of acute kidney injury leaves behind a degree of scarring and functional loss that adds to the cumulative decline over time. The second pattern is chronic nephropathy from long-term NSAID use, a gradual progressive deterioration in kidney function resulting from sustained suppression of renal prostaglandins and the associated chronic reduction in perfusion to kidney tissue. This pattern is particularly relevant to the large population of older adults managing chronic pain, arthritis, back pain, joint pain, with daily or near-daily NSAID use for months or years. The research on analgesic nephropathy has evolved significantly over the decades, but the current understanding is clear. Regular, long-term use of NSAIDs is associated with a meaningful increased risk of progressive chronic kidney disease, particularly in populations with pre-existing risk factors. A 2019 analysis published in the Clinical Journal of the American Society of Nephrology found that among adults with chronic kidney disease, regular NSAID use was associated with a significantly accelerated rate of kidney function decline compared to non-users. The relationship was dose-dependent. Higher doses and more frequent use associated with faster decline, and was independent of other risk factors. For a population that already has reduced kidney function and is on a trajectory toward further loss, regular NSAID use appears to function as an accelerant. I also want to address a specific pattern that is extremely common and extremely under-recognized. The person who takes ibuprofen regularly, not for a diagnosed inflammatory condition, but for general pain management. The low back that acts up, the knees that ache on stairs, the shoulders that have been stiff for years, and who has been doing this for so long that it has become entirely habitual. Not a medical decision, revisited periodically in conversation with a physician. Simply a feature of daily life, like taking a morning vitamin. This pattern is extraordinarily common in adults over 60, and in many cases, the person has never mentioned it to their physician because it does not seem like a medication. It is available without a prescription, it has been used for decades, and the word ibuprofen does not feel like it belongs in the same sentence as kidney damage. But from the kidney's perspective, it is indistinguishable from any other nephrotoxic exposure. The mechanism does not differentiate between a tablet bought at a pharmacy and one prescribed in a hospital. If this describes you, if you are regularly using ibuprofen, naproxen, or any other over-the-counter NSAID for chronic pain management, the most important single thing I can ask you to do as a result of watching this video is to mention it explicitly to your physician at your next appointment. Not in passing. Explicitly. How much, how often, and for how long. That information, combined with a basic metabolic panel that includes creatinine and an estimated glomerular filtration rate, will give you and your physician a much clearer picture of where your kidney function actually stands and what the implications of your current medication pattern are. Now I want to spend time on the question that naturally follows from all of this. If not NSAIDs, then what? Because the pain is real. The arthritis is real. The inflammation in the joints and the back and the hips is real. And dismissing that reality without offering alternatives would be incomplete and unhelpful. There are several evidence-based alternatives to regular NSAID use for chronic pain management in older adults, each with a different mechanism, a different evidence base, and a different risk profile. None of them is a perfect substitute for every person in every situation, which is why the conversation with a physician who knows your specific circumstances is irreplaceable. But the landscape of options is broader than many people realize. Acetaminophen, paracetamol outside North America, does not inhibit prostaglandin synthesis in the kidney, and does not carry the renal risk of NSAIDs when used at recommended doses. The important caveat is liver toxicity at high doses. The maximum recommended dose is 4 grams per day in healthy adults, lower in those who drink alcohol regularly or have liver conditions. But within appropriate dose limits, acetaminophen is substantially safer for the kidneys than NSAIDs in this age group. A 2021 Cochrane review concluded that acetaminophen provides clinically meaningful pain relief for osteoarthritis, the most common source of chronic pain in older adults, at doses that are liver safe. Topical NSAIDs, diclofenac gel, available by prescription and in some formulations over the counter, deliver anti-inflammatory medication directly to joint tissue through the skin. The systemic absorption is dramatically lower than with oral NSAIDs, which means the concentration reaching the kidney is a fraction of what occurs with an oral tablet. For localized joint pain, a knee, a shoulder, a hand, topical diclofenac provides anti-inflammatory analgesia with a substantially reduced nephrotoxic risk compared to its oral counterpart. Multiple clinical trials have found it effective for osteoarthritic knee pain with a favorable safety profile. This is not a commonly discussed option in primary care, but it is one of the most relevant harm reduction strategies available for older adults with localized joint pain who have been relying on oral NSAIDs. Physical therapy, and specifically targeted therapeutic exercise, have consistent evidence behind them for chronic musculoskeletal pain management, particularly osteoarthritic knee and hip pain. The mechanism is both mechanical, improving joint stability and load distribution, and neurological through the modulation of pain processing pathways that occurs with regular movement. A 2015 meta-analysis in the Annals of Internal Medicine found that exercise therapy reduced pain and improved function in knee osteoarthritis to a degree comparable to NSAID therapy, without the systemic risks. Exercise is not appropriate for all pain conditions and all patients, but for the most common sources of chronic pain driving NSAID use in older adults, it is one of the most evidence-supported long-term strategies available. Omega-3 fatty acids, found in fatty fish such as salmon, mackerel, and sardines, and available in concentrated fish oil supplement form, have anti-inflammatory properties through a mechanism entirely distinct from prostaglandin suppression. They shift the balance of eicosanoid production in inflammatory tissue toward less pro-inflammatory mediators, reducing the inflammatory signal without blocking the prostaglandins that the kidney depends on for perfusion regulation. Omega-3 fatty acids, found in fatty fish such as salmon, mackerel, and sardines, and available in concentrated fish oil supplement form, have anti-inflammatory properties through a mechanism entirely distinct from prostaglandin suppression. They shift the balance of eicosanoid production in inflammatory tissue toward less pro-inflammatory mediators, reducing the inflammatory signal without blocking the prostaglandins that the kidney depends on for perfusion regulation. Heat therapy, transcutaneous electrical nerve stimulation, commonly known as TENS, and certain topical preparations including capsaicin and menthol-based products all have evidence supporting their use for specific types of chronic pain, particularly the musculoskeletal pain that drives the majority of over-the-counter NSAID use in older adults. These are not replacements for medical pain management in serious conditions, but they are legitimate adjuncts that can reduce the need for systemic pharmacological analgesia. I also want to address a question that comes up consistently in this context. What about the kidneys themselves? Is there anything that can be done to support kidney function and slow the rate of decline that occurs with age, or reverse early damage that may already have occurred? The honest answer, grounded in the nephrology literature, is that the most powerful interventions for kidney health are protective rather than regenerative. The kidney has limited capacity for structural regeneration once significant scarring has occurred. This is why prevention, understanding and avoiding the exposures that accelerate damage, is so much more important than any intervention that comes after the fact. But in terms of modifiable factors that genuinely influence the rate of kidney function decline, the evidence points to several that are within your control. Blood pressure management is perhaps the single most important factor outside of specific nephrotoxic exposures. Elevated blood pressure exerts direct mechanical stress on the glomerular walls, accelerating the scarring and functional loss that characterizes progressive chronic kidney disease. Every 10 millimeter reduction in systolic blood pressure has been associated with a meaningful reduction in the rate of kidney function decline across multiple longitudinal studies. If your blood pressure is not well controlled, addressing that is more important for your kidney trajectory than almost any dietary or supplemental intervention. Hydration, genuine, consistent, adequate hydration, is protective through the simple mechanism of maintaining adequate blood volume and renal perfusion. For older adults whose thirst mechanism is blunted, this means drinking water deliberately and regularly rather than waiting for thirst, which in this age group is not a reliable signal of hydration need. The common guidance of 6 to 8 glasses of water per day is a reasonable starting point, though individual needs vary based on size, climate, activity, and other factors. The goal is consistently pale yellow urine rather than concentrated dark yellow. Limiting processed food sodium is relevant through its effect on blood pressure. The relationship between dietary sodium, blood pressure, and kidney function is well established. And in a population where hypertension is already common and kidney function is already reduced relative to younger adults, Meaningful sodium reduction has a proportionally greater protective effect. Processed foods, including packaged snacks, canned goods, preserved meats, and many restaurant foods, are the dominant source of dietary sodium in most Western diets, not the salt shaker at the table. Avoiding other nephrotoxic exposures, including certain herbal supplements, contrast agents used in some imaging procedures, and other medications with known renal effects, requires awareness that many older adults currently lack, because the labeling and communication around these risks is inadequate. If you are scheduled for imaging that involves contrast dye and you have reduced kidney function, this needs to be explicitly discussed with your medical team beforehand. Certain herbal supplements, including some sold for joint pain, weight loss, or general wellness, contain compounds with documented nephrotoxic potential. Aristolaucic acid, found in certain traditional herbal preparations, is one of the most potent kidney toxins identified in clinical medicine. Aristolaucic acid, found in certain traditional herbal preparations, is one of the most potent kidney toxins identified in clinical medicine. Before adding any supplement to your routine, verifying its safety profile with your physician or pharmacist is not optional caution. It is necessary. But even in adults without a formal diabetes diagnosis, chronically elevated blood glucose, prediabetes, metabolic syndrome, damages the glomerular filtration apparatus through glycation of proteins, oxidative stress, and inflammatory signaling. The relationship between glucose control and kidney function is continuous and dose-dependent, not a cliff edge that only becomes relevant once a diabetes diagnosis is made. I want to close by being direct about what this conversation is and is not. It is not a message that over-the-counter pain medications are uniformly dangerous and must be avoided. That is not what the evidence says, and it is not what responsible medical communication looks like. These medications have legitimate uses, and for short-term use at recommended doses in people without significant kidney disease or other compounding risk factors, the absolute risk of kidney damage is modest. What this conversation is, specifically and intentionally, is information about a pattern of use that is extremely common in adults over 60, that carries a well-documented and largely underappreciated risk for kidney damage in this specific age group, and that in many cases continues unchecked simply because no one explained the mechanism clearly, and the damage accumulates without any symptom to signal it. You are over 60. Your kidneys are not what they were at 40. The medications available on the shelves of every grocery store in this country can affect them in ways the packaging does not adequately communicate. That is information you should have. What you do with it, in conversation with a physician who knows your specific health picture, is your decision. But decisions made with full information are different from decisions made without it. And the gap between what the nephrology literature knows about NSAID-related kidney risk in older adults and what most older adults have been told about it is large enough that I think it matters to close it. If anything here prompted a conversation you plan to have with your doctor about what you are taking for pain, about whether anyone has checked your kidney function recently, about what alternatives might be appropriate for your situation, that is the outcome this video was designed to produce. Hit the like button if this gave you something useful. It tells the platform that detailed, evidence-grounded health information for adults over 60 deserves a wide audience. Subscribe and turn on notifications. Every week there is one video here that takes the time that a routine medical appointment often cannot, explaining not just what, but why, not just the recommendation, but the mechanism behind it. Leave a comment below with this. Are you currently taking ibuprofen, naproxen, or another NSAID regularly, meaning more than a few times per week? And has your kidney function been checked in the last 12 months? You do not need to share personal details. Just yes or no. That question, asked of yourself honestly, may be the most useful thing you take from today.